Good morning, everyone. So we're here to talk about our ambient listening project with our project of pragmatic trial operations to learn from what we do and do what we learn, how we are integrating research into health operations. I'm here with my colleagues, Dr. Majid Afshar, Dr. Joel Gordon, and Dr. Jason Dambach, who will speak a little bit more about our project and how we are integrating the learning health system work of ICTR with the operations work of UW Health. So ambient listening is transforming our documentation burden by using technology. So clinical documentation in the electronic health record, or EHR, has become increasingly burdensome for physicians, leading to increased physician burnout and other negative impacts. And one way the folks have thought about how to reduce that burden is by using ambient listening artificial intelligence scribes. So this is apps that can be used through Haiku on the iPhone that you hit record. It will record the patient interaction during the clinical visit, and then it will summarize it into a note template for the physician to review and set. Very simplified version of it. We're happy to speak about it more, but that is a briefest overview of what it is. And it really has the potential to reduce the burden and enhance physician-patient encounters. And this technology, this tool, it's coming to light at the same time as we're seeing this increase in physician burden and lower well-being. And so it was really well aligned with the UW Health's key initiatives in order to kind of meet the key aims that are set forth by UW Health. And so the other thing that's happening at the same time is we're building up our ability to use this LHS framework to have research rate analytics for operational pursuits. And so the LHS framework was well suited to bridge that gap between the innovation and effective implementation by enabling continuous improvement through the data-driven PDCA cycles to gather evidence, to refine it, and optimize it for use in the clinical practice at UW Health. In order to do this, we really needed a close collaboration between UW Health's operations team and the ICTR LHS team. These teams are multidisciplinary, large-spanning, having different priorities, different interests, and different expertise. And by having that close collaboration between the two and that team science approach, we were able to work together, continue to work together to optimize implementation. And what we came up with, which is somewhat unique in order to do this, is our pragmatic trial operations playbook. And part of that is our in-process governance structure, which you can see in the slides, has several different stages and groups within it. And each one of those groups provides their expertise. They have their own domains that they have their work streams with, that they can work through any problems that are coming up. They help align the research initiative with the operational goals so that it's a pragmatic trial that we are working through together. Very quick overview. I will now turn it over to Dr. Joel Gordon to speak a little bit more.
Thanks, Felice. Felice talked a little bit about, let me back up to John. I want to make a clarification. You had said research grade and at the pace of operations, and that implies the operations is fast? No. The operational pace is hurry up and wait, and that's the way the truth of healthcare operations all along. It's a fast, slow, fast, slow, fast, slow, and so I think the pace is not necessarily an implied that it's always faster. And so that's been a unique thing that we've grown to accept as in our trusting relationship between UW Health and ICTR. The LHS implementation design that Felice was kind of talking about with a lot of governance is because documentation is one of those things that is hard to govern. It's hard to govern because if you think about it, what is a document? The document in healthcare is multiple different perspectives for multiple different needs, multiple different people, all coming from one document. And so you have to include all those multiple different perspectives, and that's what required this significant, more complex governance that we designed together. Going from the design to actual the pragmatic implementation required us to start alpha because we know nothing about this technology. We don't know anything about its adoptability. We don't know how it's going to land in our culture. And so we actually did a specific alpha phase just to learn. And so there's that thank you here to the 22 physicians and providers that did the alpha work. in addition to the team that did the work behind the scenes, because we had to learn the go live, we had to learn the training, that sort of thing, and design what we were going to do after it. We just knew we were going to do something, and it was called the beta phase, but we didn't know exactly what. And it was through that alpha we learned what we could do. And then in the beta phase, it was in 4 different phases, actually, where we did 3 different sequences, bringing in 22 folks. Later, I'm going to talk about how did we get buy-in. And you'll see general implementation was going to follow beta, but you see it doesn't. It's purposeful that general implementation looks like a triangle on top, and we'll talk about that later. And that's, I think, everything I should say from this slide. The best practices for sustaining a learning health system project that we learned so far is securing stakeholder buy-in, and particularly in something like this that's so massive and, as I mentioned previously, has so many stakeholders. We're constantly identifying more. So our team did kind of have to be very, very nimble, but at the same time willing to include and not be exclusive, because exclusivity is would kill a project of this magnitude. The workstream groups did accept their responsibilities, and they did the needs and set up and monitored the project with the increasing efficiency and sustainability as we went, developing more and more trust between the teams that are, again, multidisciplinary, as Felice had highlighted. The PT Ops playbook was a plan that we wanted to get to, but it had to write itself. It was kind of a living document, a living method, but aligning those operational and research goals, metrics, and timelines just to make sure we end up on time, on budget, and we did darn good job with that. I think we move on to the questions.
All right, terrific. So one of the questions that we've got is, why was this project selected as a priority for implementation?
Yeah, and that's a great question. I'm going to answer it, and it was threefold in my opinion, and we spoke a little bit about them. So the question I'll repeat, just in case it didn't come across, is why was this selected as an executive level ICTR learning health system combination work? First of all was alignment with that strategic plan, okay? And the strategic plan is, one, that we design our future workforce and workers, okay? That was number 1 on that list. Number 2 on our strategic alignment is making sure we offload providers and work staff from the excessive burden of clerical work. And the third thing that's in our strategic pillars is about being financially, delivering value and being financially solvent as far as that goes. So those are the 3 things that I think was about alignment. The last thing I'll say about alignment is that you also have, actually, alignment is one thing, resonance is the other thing. It has to resonate with the leaders. This was not hard. In the world of AI, large language models, and specifically ambient listening, this is just buzzword. It really gets attention. We immediately had natural resonance to alignment and resonance. That's the first thing. The second thing is operational opportunity. We had massive operational opportunity. We have 5 different documentation modalities at UW Health, not different than other organizations, but it starts on the spectrum from manual entry, just free text typing, to epic entered tools like smart forms and smart tools and macros. The next is transcription. Phone transcription is still alive and being utilized to create a document. The fourth one is front-end speech. We knew it as Fluency Direct is what our brand is of that, but it's front-end speech. And then the fifth one is scribe use. So those are 5 modalities we have running to create a document. If you benchmark us compared to our peers, interestingly, we have a lot more of the first and the last than our peers. We have more scribe than our peers. We have 3 times more people typing. Unfortunately, these are the most expensive modalities that an organization can use. Fiscally expensive for us to use scribe. Physically and cognitively expensive for us to be free texting as much as we did. And so there is the operational opportunity. The last reason that this was chosen is because of, innovation opportunity. Everyone's doing this. We're not unique to be using front-end speech, to use ambient listening. Ambient listening, however, is the first time in my career we found something that was like an Atari, i.e. plug and play. It has the ability, because it's technically mature, and because it is integratable into our EHR, it is almost plug and play. I think the industry got lazy with the plug and play and started doing that at a high rate. And it left us with lots of gaps in our implementation science and understanding what we're doing. Let me be a little bit more clear in this. Sorry, I'm taking the whole darn time here. But where is the gap? If you interview people, even those that have enterprise license, they'll say things like these mixed messages. It's revolutionary. It is mind-blowing. It's the best thing ever. Those are the words they say. And then you talk with them about, okay, well, tell me about your implementation. Even if you have an enterprise license, meaning anyone can do it, 25 to 30% of the providers are using it. The majority are not using it, even though they could, okay, in most of those organizations. Then if you look at the individual level, some people are using it, not using it, try it and don't use it. Some people use a little bit, and some people use it as exclusively. It does look like maybe related to specialty, but interestingly, even in the same specialty, in the same hallway, we have variations between Dr. A and Dr. B. Why? We don't know, because we're doing such fast plug-and-play implementation, we're not studying it. And so that's, I think, the difference of why this was chosen, is there's an opportunity for us to supply industry best practice knowledge, but we have to study it. So I'm going to stop, because I think that was more time than I was allowed.
All right. Thank you so much, Dr. Gordon. Very quickly, Felice and Majid, I wonder maybe you could tell us a little bit more about how you approached reconciling the research and operational needs of the project.
Oh, sure. So, I think Joel has, the IS folks had a great plan with the operations team to figure out, the technology was there, the integration, interoperability was there, but it is still a new technology, right? Like, we don't quite know what are the side effects, what are the human-centered effects, what are the challenges of getting the human in that technology to use it, right? To Joel's point, utilization could be better. Maybe someone has some different motivations for using the technology. So to Felice's point, I'll let her speak to it in terms of what are some of the science that was, UW Health and the University of Wisconsin wrote the book on. But from my standpoint, when Joel called and said, hey, can we use the LHS framework on this? To us, it was like, well, you guys are doing this QI initiative. Let's add this layer on top that gets you the research expertise that our campus has. We got amazing industrial engineers. We got amazing implementation scientists who wrote the textbook on how to integrate these emerging technologies into workflows. Because in my opinion, while these are plug and play, I don't think plug and play is always the right answer. I think we have to revolutionize how we think about these new AI technologies, and we have to redesign our workflows around it. And actually, that we ended up doing a little bit of that, right? The technology was there, it was plug and play, but the way we used it wasn't plug and play. And I think Jason can speak to that after maybe Felice weighs in on the engineering or human-centered design.
Yep, absolutely. So from our research perspective, we really needed to understand the barriers and facilitators for providers to actually be using this technology as a tool and not occasionally using it as a toy. And so to do that, we had to really understand and talk to stakeholders in different specialties who are using it in different ways, who might have had these different motivations, to understand where we could optimize or change different pieces of how we recommended the use of the tool, potentially different educational components, different adaptations we could make. We also really need to understand the workflow and process that the different providers were using, both themselves and then how the patient was experiencing it. By understanding all of that, the goal is to optimize its use so that it's better utilized, it's more acceptable to the providers and the patients, and then also leads to these outcomes that we're hoping for. In addition to acceptability and usability, it's also increasing provider well-being, which is kind of one of the key initiatives of UW Health that we're hoping to improve on.
Jason, you're the boots on the ground leading this effort. What did you notice when you first started this work? We always joke as Jason was the gold standard, and so we had to say, who are the bronze and silver standards?
The coders will be looking closer at my stuff spot. Yeah, I'm Jason Dambach. I'm a primary care internist and I'm the user experience lead for this. As Joel mentioned, we kind of needed to do alpha to know what to do with beta, right? So learning from alpha, the software being plug and play into a piece of hardware that you're already carrying with you was something that we turned it on, and we thanked the alpha users for testing it and said, this is a tool we need. Your primary goal is utilization. We want you to use it in as many scenarios as you can, so you can tell us, where does it work? Where doesn't it work? Where does it need some sort of tune-up? Right? So that was, the alpha users were kind of hand up, we want to try this. There are a lot of informaticists, a lot of early adopters for this technology. So we expected them to have high utilization and then give us feedback. And we pestered them, basically. We asked them, like, hey, tell us what could be better about this. And then having the layer of all of this data coming out of it, we very quickly realized that with alpha, we needed to put some guardrails on it as well. So while the software is plug and play, you've got the hardware in your pocket already, you put it down between you and the patient, you have a conversation, and it generates a note. There are regulations around documentation, right? So there are certain things that we need to do. And I'll bring the one to light that kind of was one of the, a little bit of a barrier that we had to put a guardrail around. Because you're recording the patient, you need to document the consent, right? And the consent, you can build it into a smart tool, right? And that smart tool can be linked to the tool that brings all of the ambient documentation into that. And what we found from alpha users who, while they are usually tech savvy, they also kind of like to develop their own workflows. So not having consistent workflow around that led us to find out very quickly in alpha that we needed to kind of standardize this. All right. And so with standardization comes sometimes efficiency. Certainly you can capture the things that are required on all your documentation by standardizing it, but not everybody likes the same standardization. Right, so then you run into barriers with people adopting it. Some people will use it when they had free reign to do whatever they wanted with it. We're using it at a higher rate than once we standardize and put that in there. So that was one of the barriers that we ran into. Speaking of plug and play, though, one of the facilitators to this was this out of the box. Joel came to me on May 20th and told me, you're going to have this live in your pocket. And I didn't. Stole. Right? He said, this is going to be turned on in your pocket on June 20th. And I laughed. I laughed at him at this conference. Like, that operationally, I can't believe you're pushing that. But the operational teams came together, and the research team layer on top of that. This is what I was amazed by with the collaborative work here, is that a collaborative space shared by operations and research staff together, where people were putting their updates there, and then a collaborative channel where people were chatting. And because of the fire that was lit under everybody for this short timeline, that channel kind of kept people going. And so something got brought up that morning between like multiple chats in a day. We had the solution, and we're moving very rapidly to getting implementation, get the data we needed out of this, and supporting 22 providers right from the get-go.
Very rapid PDCA.
Yeah, yes, there were quite a few cycles just with the alpha group where we learned they had the alpha providers all had their own channel for support to provide feedback, and in real time they were getting support back as to how to troubleshoot things. The vendor that we're working with was very responsive to that as well. So between research, operations, and the vendor themselves, there was a lot of collaboration, and that made this go quite rapidly at the beginning.
Well, one more question, maybe?
Yes, wonderful. Thank you so much, Dr. Dambach. Knowing that the outcomes of this project are not totally finalized yet, I'm going to ask you quickly, how have you made the case to UW Health for the project's ROI and sustainability?
I will talk about ROI, or getting the buy-in, and you've pondered on the sustainability. Sure. So
1 minute each, please.
yes, exactly. Buy-in was easy because of the buzzword, first of all, that I mentioned previously. Secondly, we got the buy-in because remember that little kind of part of the implementation, general implementation, kind of got on top of beta because we realized beta were still some extra early adopters, and we needed to kind of be more comprehensive and find someone like me, influencers, and leaders. And so they got an extra little kick starting this already. So when we get to the actual general implementation, we already have our spokespeople in place. And that was super important to realize. And that was a lesson we had as we went through it, that the beta was our discovery about the research, but we need a voice in the practice for the implementation. And so that was where we quickly accommodated that across the team, say, whoop, turn the model and put this in general implementation on top of the research. Thanks again, Majid, for helping us with getting that arrangement.
You're very welcome. So I'm looking forward to the research that's going to come out of these beta waves to inform us more on what we can do sustainability. We've put the guardrails in place so that people can use this. We're probably not getting, we have a lot of variability in users. So my utilization rate, the only time I don't use it is if I accidentally push the wrong button and it closes the note on me, right? Otherwise, I use it 100% of the time. And then there's other people that are down in the 10s and 15%. So
And you're not in the clinical trial phase. This was part of the trial phase.
I'm interested in beta informing, like when we go to general implementation, all of the best practices we need to share when we roll this out to more and more physicians. And then while I'm very impressed with the way that this works, and it works really well for my workflow, it isn't for everybody. So we're going to learn more from different specialties, and then best practices will develop from there. So that's, I think, how we're going to sustain this.
Wonderful. Thank you all for your time and your expertise. And we're going to switch, say goodbye to the ambient listening team and bring in our predictive ED to inpatient bed team.